a very important topic and very important person to talk about. Vitiligo, we all know that it is very distressing and disturbing to the patient by, parents or relatives. So it is a social stigma, whatever it may be. People want treatment, and the medical management to a certain extent may help you to correct the depigmentation, but there is limitation to treatment, medical treatment for vitiligo. In that situation, dermatosurgery or vitiligo surgery has come in. And there are a lot of, if you go to the history, there are split skin graft, even now it is performing, then punch graft, then later the melanocyte transfer, blister transfer, blister grafting, all those things are available and practiced by almost all dermatologists except me. Anyway, this is an important area. One should be aware and one should get a hands-on training of vitiligo surgery. And the patients may demand rather for a surgical procedure because they want immediate result. But one should remember that this is not always possible. You might have heard that vitiligo is unstable. And when it becomes unstable or when it is unstable, it is better not to touch vitiligo. And there are controversies about what the definition of stability. So we have to get a clarification before you put your knife on vitiligo. And this is what Dr. Ashique is going to do. And I am sure Dr. Ashique is well known to you all. He is very famous in IADVL forum. And he is presently editor of Indian online journal of IADVL. And more than that, is a good human being. And he has a lot of concern of patients. And he translates this to his practice. So over to you, Ashique.
Thank you, sir. Thank you very much. It has been very long since we attended a webinar because now we are all back into the physical thing and it feels good, wonderful, and thank you very much for the opportunity. In fact, I really cherish. As sir said, vitiligo is here, very much here, and vitiligo is here to stay. It is not going to go anywhere. And more people are being burdened by this problem. And more people are taking up vitiligo surgery. And obviously, the more we do, the more we get confused. And the more we need to know when to do or not to do. Because not doing when not to do is equal. Like the orthopedic surgeries or any other surgery for that matter, it is not just repairing something and once the post-op period is over, the patient comes back to normal and lives. Whereas in vitiligo, we are actually managing a medical condition surgically. So there are a lot of things that we need to take into account before we actually put the knife, as sir said. So this is my conflict of interest. I have nothing to declare with any of the things that I'm discussing in this lecture. We know the classical classification of vitiligo, and these are the three things that are regularly done. One is the, as sir said, this is the punch grafting, suction blister epidermal grafting, and melanocyte transplantation. Slit skin grafting is there, and cultured epidermal suspension, which actually is a technically challenging process and is done only in very few centers in India for obvious reasons. because non-cultured technique is much easy and doable for most of us. Okay, suction blister is there, and punch grafting. It's the simplest thing which we all can do and should be undertaking in ideal candidates. See, beware of blind commitments, because you get a photograph on. So all of us, I presume all of you, including Crichton sir, is doing vitiligo surgeries. So he said he doesn't do. Well, all the people, we all have this problem of WhatsApp consults. We get pictures from patients, relatives, doctors, colleagues, dermats, non-dermats, everything. You might get a picture saying, is this patient surgically correctable? Because when your friends come to know that you are doing surgeries, they tend to do that. My advice is, don't commit surgery without seeing the patient properly. Because there is a lot of things that comes into picture before we actually commit the surgery. The stability part, the examination part, the motivation part, how prepared they are, the expenditure. Because all these things don't get translated in your WhatsApp chat. So don't commit surgery when you are blind. In the sense, the patient is not sitting in front of you or unlikely to see you in person. Next is your competence. You need to ask yourself, which is my area of expertise, even in vitiligo surgery? Which one have I done enough? Which one am I good enough? Which one am I wanting to learn? Which one am I continuing to do? Which are the things that I have been doing recently and I had to abandon for some reasons? So all these things are very important, because if you are not competent in some particular thing, and if you take up a difficult case for that particular technique of surgery, then you will be in a soup on the table, because you will get stuck. I'll come to the situations of how you will get stuck in the coming slides. So depending on your expertise, you have to decide which surgery has to be taken up. So if you're not competent in a particular procedure, don't take up big cases till you become competent enough. The logistics of it. Vitiligo, though we are all basically physicians. That is the problem with us handling surgical cases. We are not properly, at least up to my generation and even, we were not properly trained to handle the surgical situations and things. So we had to learn from workshops and seminars and leading ourselves and other things. So there are so many things that a surgeon has to keep in mind. One is the time when he prefers to do surgeries, unless there is an emergency. I would advise you to do surgeries only during this time, preferably 9 o'clock to 3 o'clock in the afternoon. Because that is the time where you are fresh, your team is fresh, your colleagues are around. That is very important. In a hospital, if you're doing surgery, all the people, if there is, because we simply cannot predict emergencies. If something goes wrong, if you call for help, we should not get an answer saying that doctor is gone already, he has finished his OPD and gone. Because we waited for our OPD to get over and post the case. Imagine doing surgery starting at 6 o'clock in the evening, and patient gets a vasovagal attack or something like that, or an anaphylactic reaction, God forbid. So that is very important, the time when you operate. The reagents that we use for melanocyte transplantation, they are notoriously known, unfortunately, for a very short shelf life. So the problem with these reagents are they get expired very quickly. So you have to have a check of the situation when these reagents are, you need to have a checklist. When is it getting expired? Because they are kept in the refrigerator and it will be ice. You won't be able to read it every time. So you should have a physical paper where you have written it and keeping track, because an expired reagent, the result is unpredictable. And this is not something that you can repeatedly do and kind of, you are prepared, patient is prepared, so many things are being sacrificed, and you are doing this procedure with an expired reagent, and the result is going to be unpredictable. We cannot guarantee anything. At least in Kerala, most of the parts now rains are coming up. We have generators, we have UPS, we have everything, but still, if you are doing a repeat back-to-back procedures and something, make sure that your power supply is adequate, because you will need energy to do for the incubator and centrifuge to work. You need electricity for the micromotor to work. So if you don't have a UPS or a electricity backup, you should be very careful when you choose to be a surgeon, because that is very important for your infrastructure setup. Hostile environment. You will be called to do vitiligo surgeries in various parts of the country or world or whatsoever. You will be asked to do workshops in conferences. You might be invited to do surgeries in various departments and other things. Before you really commit, you have to make sure that the environment there is good for a surgical thing. We cannot do surgeries in the auditorium. We cannot do surgeries in the hotel room. Just because it is a punch grafting doesn't mean that it can be done in the corridor. Because we have to respect the procedure, we have to respect the ethics, we have to respect the patient. So if the environment is not comfortable, I would say please do not do vitiligo surgeries or any surgery for that matter. Next is the team strength. I don't have much written slides. Okay, these are all pictures and me speaking. So I hope the slides are being visible or properly also in the network. See, your team is you in the lead. You may or may not have assistant doctors. You have your nurses and all those people. So unless and until your team is on duty, you cannot do a surgery properly. So surgery, I discuss everything with the patient, and before I commit the date, I call one of my nurses and tell them, see, I'm posting this surgery for the next week this day. Is that okay? And there may be, see, they're all human beings. And there are situations where they say that, you know, sir, that day I may be a little late to work. And that new staff, she may not be able to do things alone. It's a fact. So these are the things that you need to take into account also, and be very prepared. And it's a serious thing. You know, you can't just do it just like that. Stability. This is the most crucial thing in vitiligo. And I'll tell you a story. And without much details, getting into complications of how to stabilize, because that is beyond the scope of this lecture. I'll tell you a story about how I have gone through once. When I started surgery, vitiligo surgery, obviously I told a lot of my friends and I was very excited. And I'm the same excitement I still feel today also when I operate on patients. And one friend of mine referred this patient to me. Sir, by the way, I think time is not a factor, right? I'm not going slow or fast or anything. Is that okay? Okay, fine. So this girl, she's actually a paramedic. She was referred to me, and with all this thing, my friend told them that, you know, you go to this man, he will operate and you will be fine. And the moment I saw this, no, I was even more happy, because this was probably one of the first big cases that I got to do. And over and above, they being paramedic, they knew most of the things, and they were already pre-motivated. They were like pushing me, sir, okay, sir, we'll do it, sir. Whatever I say, they were saying yes. And then what happened is I operated. This is one session of melanocyte transplantation. In 2 months, I successfully failed. Nothing happened. The whole patch was still there. And they were quite okay. She was a paramedic and she knew quite a little bit of things. But I was not okay. I was totally upset and demoralized. And then I didn't know what actually went wrong. Obviously, and they were like, sir, we will try one more time. I said, please, no, I don't think the disease is ready, because I am ready and you are ready, but the disease is not ready. So we need to, this is called stability, and we need to stabilize the disease. And then I put her on immunosuppressants, started her on oral minipulse. I think I am not very sure about what I did, but narrowband UVB, and got her disease stabilized. And I operated her again. This is another next sitting of melanocyte transplantation. And you can see the result. She repigmented beautifully well. She was married, she has a child, and they still send me greetings, and they're abroad somewhere. So that is there the problem was. If you notice this carefully and see the difference with the stable patch and the unstable patch, see the border. The border is sharp. That means the boundary has been set. So unless the border is sharp, the lesion is not ready for surgery. Keep that in mind, irrespective of the time whatsoever, whatever they say. So if the border is not sharp, it is going to be a tough game. So the criteria, what the guidelines, even our IADVL guidelines and European other guidelines say is 1 year cutoff of no new lesions, no active lesions, no keepnerization. And then we can say that particular patient is an ideal candidate for surgery. There is lesional stability and disease stability. Disease is the generalized global phenomenon. Lesion is the particular patch, because there are certain situations where patient says, sir, this patch has been so since 10 years, nothing has happened, please do that. But then you have to assess the global stability, the same criteria, otherwise your donor might keepnerize. So that is the criteria which you need to keep in mind. For example, this is one reason why I said don't commit blindly. This patient actually was referred to me for surgery, which I did not operate, because you see that it was a tight wristband which was already started keepnerizing. Another gentleman, this is not a surgically correctable patient, but still just wanted to show you. See, he was still having active vitiligo. So such things can be missed out when you commit blindly. That is why I said you bring the patient to your premises if possible. See him properly, examine, discuss, and only then decide. There is no hurry. And then you have to be really sure about what you are handling. Am I really handling a vitiligo, or am I handling something else? So that is one thing which you need to know, because everything that is white need not be vitiligo, and every white patch cannot be operated surgically and corrected. And even if you operate correctly, if you don't choose the right technique, then your surgery is a failure. Even a correct procedure in a wrong setup or a wrong situation will be 100% failure. This was a case actually which was 2 times operated. You can see the corrugation on the chest, I mean on the borders and all that is dermabrasion done from somewhere else. She was operated, they gave me a history of since childhood, that is all they say. And these are situations where you should actually ask for their photographs in childhood. Then you will know whether the lesion was there or not. So 2 times it was operated, they said, and they had full faith in me, fortunately. And they came to me and they said, sir, please let us do that technique, whichever you are good at. Someone told me XYZ, all those things. I was actually, as usual, excited. I operated her with melanocyte transplantation and ended up in a reasonably better white patch where the borders got cleared, nothing else happened. And then I had to recheck the history, go back and take the history. And then I realized that it was nevus depigmentosus and not a vitiligo. Because the way they were presenting it was all, because some medicines we gave sun exposure, it was working. These things, they kind of misguide you with a purpose or even out of their ignorance. because somebody would have told them that, this operation works for you. So make sure that somehow you get it done, kind of. So they will tell all sorts of lies to make us do. Another thing is, they also don't know how well to assess the progression and other things. This is another nevus depigmentosus. It looked fine in the beginning and it reverted completely. This is melanocyte transplantation done. So you need to read the books, look up literature, and find out which is the ideal procedure for each condition. Because for the genitalia, some procedures work better. If you take up a wrong procedure for the right situation, even then the results are going to be bad. For example, lips, over the years, people have been doing many procedures, but from what I could understand, melanocyte transplantation is not a good choice for lip vitiligo. It is blister grafting that works best. Eyelids, you can do punch grafting. Melanocyte transplantation is difficult because dermabrasion is not easy if you are not competent enough. Remember the competence part. Nipple and areola, you can do melanocyte transplantation. Even punch grafting works sometimes. But melanocyte transplantation gives you fantastic result, and even the normal repigmentation of the nipple and areola comes up. Next is people who come with body dysmorphophobia. They don't tell you that I have body dysmorphophobia. They continue to complain. These are people whom you should be never be taking or discourage as much as possible, because they will never be happy. Because their idea about the disease or the situation is not going to be, you cannot match it whatever you do. So these people need support beyond us, and only these things should be handled carefully. Next is anxiety, guys, apprehension. You should handle these people very carefully. For example, I'll tell you this story. This gentleman, he came to me in 2010. Okay. He was not stable, I agree, but I had suggested surgery and he disappeared. Then he came back to me after 5 years. By then, his lesion had organized and I was not treating him. He went round. Because the moment I said surgery, he said, no surgery. I said, see, I'm not going to operate you now, but finally we may have to do it later if it doesn't work out. That word surgery made him scared and ran away. And in 2015, if you look at that picture, he's actually a perfect candidate for surgery. The borders are sharp, all the things have organized, and you can see how appreciable the stability is. And the moment I said surgery, he ran away again. And then again, he came back. And I said, see, now I don't have anything more to offer, man. And then he was talking about, sir, I have to get married, please help. See, what can I do? You have to listen to what I'm saying. Then I said, see, I can only give you surgery is the best answer. Why don't we finish it off? He said, okay, I will discuss with my parents and come. And he never came. 2019. So either he is still apprehensive or he would have got it operated somewhere else. I don't know. But these are the people. So don't take up such people unless they are fully this thing, because they might create a fuss, and they might even spoil your repute with the confusion that create. See, children are actually very difficult to handle for the vitiligo surgery part. Because blister grafting, I would say, shouldn't be taken up in children. It is a painful procedure, the donor arm and other things. A child crying, and we are not doing this procedure in a soundproof operation theater. Throughout the time, about 2 hours or 2.5 hours, this child will be crying. That makes us uncomfortable because the bystander continues to come and ask us, sir, is that okay? Everything is fine? It is fine, but the child is crying. And you are also confused because you can't expedite things. No, you can't fast forward a blister racing technique, which almost takes 1.5 hours. And if you are lucky, you can have a child who can be very friendly, joy and Josh. But I did melanocyte transplantation for him. But children should be handled carefully unless you are really, really sure that the child is going to cooperate. don't take it up. And I would say blister grafting is not a good technique for children. Coming to systemic illness. Again, another patient, I think he was referred from somewhere, Coimbatore or so. And when they called up, they said, sir, we have been asked to come and meet you for surgery. Can we come for surgery day after tomorrow? No. Okay. Then they told me, sir, he has a small problem. He's diabetic. How old is the boy? I said 25. 25, somewhere less than that. Okay, fine. And he's on insulin, sir. So he has been having it since childhood, not a problem. It's fine. I asked him to come and I examined. And then I realized that fellow is on insulin mechanism full time. He is using an app to monitor his glucose periodically. And then he is using insulin dose, titered dose, metered dose. Because it's insulin is that type of thing. And imagine in a small clinic handling such a case, it was difficult. So what it is, I sent him to a physician of my area. They were not very keen. They said, sir, we are seeing him in our place. He's fine. I said, he's fine, but I want a surgeon, a physician to be also aware that such a thing is happening in my custody on this date. So that if something goes wrong, he shouldn't be called out of the blue and explained, where I myself may not be in a position. I told them very clearly. And they went to the physician. Physician was quite okay, fine. And I operated him. And believe me, this man he was, I think once or twice he checked his insulin with the app. And he took his dose and other things. And they know it very well. They knew diabetes much better than me, the parents and the child. Young chap. So systemic illness, you need to be really careful about surgical procedures. This is another lady. She had this upper lip right side vitiligo. I posted her for surgery, blister grafting. And on the surgery day, she comes and shows me that there is, the picture actually is from a different patient, okay? I had to get I didn't have a close-up picture of that. That's why I used it. Anyway, that circle is the active herpes on the lower lip. So this is one strict no to operate. Active herpetic lesion should not be touched, even if the herpes is not on the operating site, because the vitiligo also was triggered by one such herpetic infection. So active herpes infection is not a good patient to operate. This is one patient whom I operated. He got a little bit of hypertrophic scar, and subsequently that increased. I was not very happy, but patient was quite okay because he said black color is better than my old white disease, sir. And over time, that has also improved. So you need to ask for keloids and hypertrophic scars before you operate, because some people have very bad scar tendency. So if you're going to operate on a cosmetically sensitive area, you should think twice and be very careful about the procedure. Pigment mismatch after previous therapy. You know, these kind of people who come to you with vitiligo, and these are the people actually who don't, I think there is a different type of vitiligo where the repigmentation, even if you treat, is going to be bizarre. It is not going to be a uniform pigmentation. So this lady I operated, and this is the maximum I could get. She was fine, but somehow this patient, such patients, you should be careful also. So the mistakes that you have learned over the years should teach you when not to operate. So you might fail in the first attempt, but you learn a lot. Acral vitiligo. Again, patient will come do anything on the earth if you can do something for this fellow. And he told me, sir, why don't we try surgery? I said, see, come on, it is. No, sir, we'll do, sir. It's okay, fine. I gave him some punch grafters just for an experimental basis. I knew that he also wasn't very sure. And I felt really bad. You see that? Just one punch has taken up. Where did we stand? What did we gain? Because he would have been so hopeful. though he wasn't very sure, back of my mind, he had hopes. His family would have had hopes, and we give them nothing. So these are the people whom you should actually be very, very, very reluctant to operate. Another lady, acrofacial, perioral. I did the lower lip blister. Nothing happened. Again, a successful failure and a bad memory. So coming to the vitiligo vulgaris. See, the problem with vitiligo vulgaris is it's a global phenomenon. It's all over the body. So if it's a stable disease, technically speaking, melanocyte transplantation works. But you have to understand what is the percentage of happiness that the patient is going to get once you operate. A patient with full vitiligo all over the body, not acrofacial, multiple patches over, you operate this much, okay? Your melanocyte transfer is done, and it's kind of a good repigmentation. This much was there, and I lost that boy for follow-up. I don't know. He must have improved. So from my angle, I am 100% successful, okay? But you are not reaching even 5 or 10% of the total burden of the patient. So are we really justified in operating vitiligo vulgaris unless it is a very obvious segmental overlap on a vulgaris patient? Because they might have a segmental patch here. He also has other things. Then he specifically says, sir, please correct this thing. That is fine. The rest I'll live with it. That way, okay. So you have to ask yourself, what percentage of happiness is the patient going to get after the surgery and recovery? If that is going to be 100% or even 80% or even 75% or more, then you are justified in operating. Otherwise, I wouldn't touch this man. So never without seeing the patient in advance. Logistics, expertise, unstable disease, unstable lesion, unsure diagnosis, anxiety, body dysmorphophobia. These are the things, all the things that I've said so far in a nutshell. So these are the things you need to be careful. So my only take-home message is, knowledge is being aware of what you can do, and wisdom is knowing when not to do it. Thank you very much. I hope it was useful for you. All the very best, and continue doing and decide when not to do. Thank you very much, Crichton sir, for the opportunity.
Thank you, Dr. Ashique. You have given a very pertinent advices to the young budding dermatologists, and they should keep your advices in their life so that they could do a better job with respect to vitiligo surgery. And this is a very practical session, as I should say, and that is their breadwinner in the years to come. Hope you will all enjoy the talk by Ashique. Thank you, Ashique.
Thank you, sir. Thank you very much.